In this sketch, we'll discuss a unique complication of pneumonia that you'll likely run into at least once on your inpatient rotation: parapneumonic effusion and empyema. Today, we're heading to fencing class. You know, that sport you always wanted to call sword fighting but couldn't because Braden would correct you with that uppity tone of his. I don't care what you call it, Braden, you're fighting people with swords. Anywho, remember our pleural effusion DDX sketch from earlier in this chapter? If not, head over there and refresh yourself, because we'll be building on those concepts in this sketch. All caught up? Well then, without further ado, let's lunge in. Parapneumonic effusions are pleural effusions that form in the pleural space adjacent to a bacterial pneumonia. Remember our recurring sketchy symbol for pleural effusion, the sopping wet pleural shirt? This time it's in the form of those nasty sweat stains on the Spencer's onesie. Looks like someone got in a good workout. And see his rusty chest plate sitting there next to him? That's to remind you that parapneumonic effusions are pleural effusions that form next to bacterial pneumonias. Parapneumonic effusions can be divided into three groups: uncomplicated, complicated, and empyema. Uncomplicated parapneumonic effusions are the most common type and form when lung interstitial fluid increases during pneumonia and moves into the pleural space. When the resorptive capacity of the pleural space is exceeded, a parapneumonic effusion results. At Sketchy, uncomplicated parapneumonic effusions are represented by this novice class sign since, well, novices are pretty uncomplicated. Regardless of the type, parapneumonic effusions are exudative effusions. That's why we've brought back our recurring sketchy symbol for exudate, the emergency exit sign. For more details on the differences between exudative and transudative pleural effusions, head back over to our pleural effusion DDX sketch. Complicated parapneumonic effusions, on the other hand, are characterized by bacterial invasion of the pleural space. Hence our recurring sketchy bacterial lanterns lighting up the expert class area. Speaking of which, things aren't looking great for that quote-unquote expert. Should have parried, guy. Should have parried. Often, complicated parapneumonic effusions and empyemas contain inflammatory fibrous adhesions that can create little compartments of fluid, also known as loculations. We'll talk more about those a little later in this sketch. Speaking of empyemas, they take things one step further. At this point, bacteria have infected the pleural space, leading to the presence of frank pus. And what better way to emphasize the flaky rind and gooey pus-filled insides of an empyema than a hot, gooey empanada? Now that you know what these terms mean, let's take a look at how parapneumonic effusions and empyemas present. The common theme in both parapneumonic effusions and empyema is the presence of a bacterial pneumonia, so you can probably imagine what patients might present with. The most common clinical features of bacterial pneumonia with parapneumonic effusion or empyema are prolonged fever, represented by our recurring sketchy symbol, the flame bandana, and pleuritic chest pain, represented by the fencer's shark tooth necklace. So hardcore. Of course, other common presenting symptoms of pneumonia, such as cough, dyspnea, and sputum production, may also be present. However, these features are generally not helpful in differentiating patients with parapneumonic effusion from those with run-of-the-mill pneumonia. One other historical clue you should look out for is the time course. Complicated parapneumonic effusions and empyemas tend to present later because it takes time for bacteria to invade and colonize the pleural space. Hence the flyer for late classes tacked up on the lockers beneath the expert class section. Ugh, those experts. Always gotta be fashionably late. When it comes to empyema specifically, there are a couple of conditions to watch out for that can increase your patient's risk. The first is aspiration pneumonia, represented by that half-eaten piece of empanada the Spencer's coughing up. Aspiration pneumonias tend to be caused by anaerobic bacteria, which are indolent and grow super slowly. This slow growth gives those anaerobic bacteria time to invade the pleural space. By the time aspiration pneumonia is identified and treatment is started, the bacteria are already in the pleural space and having an all-out empanada party. Woo! Therefore, ask about aspiration symptoms and look for a medical history that predisposes to aspiration, such as stroke and neuromuscular disease. In addition, immunocompromised patients, represented by those recurring sketchy crutches in the corner, are at increased risk for developing empyema, so look for conditions that can cause immune deficiency, such as HIV or organ transplant. While the history can give you some clue that you're not dealing with a run-of-the-mill case of pneumonia, it's the objective findings that will really help you nail the diagnosis of parapneumonic effusion. On physical exam, your goal is to differentiate a lung consolidation from a parapneumonic effusion. Time to let those fancy pulmonary exam skills shine. Unlike the crackles and increased tactile fremitus that you might expect with a consolidation, the area of lung affected by a parapneumonic effusion, or empyema, is characterized by decreased breath sounds, represented by this kid struggling to hear sounds through that thick fencing uniform, and decreased tactile fremitus. Just like this kid, you'll be struggling to feel the vibrations through all that nasty exudate floating in the pleural space. When it comes to labs, patients with pneumonia and a parapneumonic effusion won't present all that differently from patients with regular old pneumonia. For instance, a CBC will show an elevated white blood cell count, represented by our recurring sketchy symbol, the white bird or helmets sitting high up on that shelf, just as it would in patients with run-of-the-mill pneumonia. Admittedly, blood tests won't do much to help you diagnose a parapneumonic effusion. It's the other tests you can order that'll get the job done. First up, the classic chest X-ray. But we're not going to focus on that hunk of consolidated lung parenchyma you'd expect to see in patients with pneumonia. Instead, focus your eyes on the corners, the costophrenic and cardiophrenic angles, to be precise. The classic presentation of small and medium parapneumonic effusions on chest X-ray is blunting of the costophrenic angles, represented by this kid gently peeling the corner of his sweaty chest plate off his body. Notice how it blunts the corner of the X-ray design on his chest plate? As the effusion grows larger, you might see a meniscus over the affected costophrenic angle. Ultimately, massive effusions can white out an entire section of the affected lung, represented by this large white corner of the chest plate being peeled up. An upright chest X-ray is a great place to start, but once you suspect a parapneumonic effusion, you'll probably want more specialized imaging for better characterization of the disease. The primary goal of additional imaging is to identify loculations that can form in complicated parapneumonic effusions and empyemas. Since loculations wall off one part of the effusion from another and prevent the free flow of fluid, we've used these locks on the lung-shaped lockers to represent them. In the past, a lateral decubitus chest X-ray was the next imaging test to order to evaluate for loculations. Hence the white lock on that sideways lung-shaped locker. If the pleural fluid moves freely from the costophrenic angle to the dependent side of the lung on a lateral decubitus chest X-ray, represented by these two lung-looking water bottles here, you can be pretty confident that you've got an uncomplicated effusion on your hands with no loculations. As other imaging modalities like ultrasound and CT become more readily available, lateral decubitus chest X-rays have become increasingly rare. Nowadays, when you suspect a complicated parapneumonic effusion or empyema, your next step should be to get an ultrasound of the affected area. Pulmonary ultrasound, represented by our recurring sketchy bullhorn resting inside this locker, not only visualizes loculated effusions, it's also helpful in finding a site for thoracentesis, which we'll get into a bit later. On ultrasound, look for the characteristic fibrous walls separating loculations from each other. Fluid cavities in non-dependent areas are another clue you might be looking at a loculated effusion. Ultrasound is a quick way to get an idea of the type of effusion you're working with. But the imaging modality of choice to diagnose loculated parapneumonic effusions and empyemas is a chest CT with contrast, represented by our recurring sketchy symbol, the black CT cat, complete with the contrasty yin-yang collar. IV contrast enhances visualization of the pleura, making the walls of those loculations easier to see. On CT, empyema classically produces the split pleura sign, in which contrast-enhancing thickened visceral and parietal pleura appear separated by a large collection of hypodense fluid. It's symbolized here by the thickened outer layers of that toasty empanada, separated by that gooey gray filling. Tasty? As we mentioned earlier, the presence of loculations means you're dealing with a complicated parapneumonic effusion or empyema. However, parapneumonic effusion isn't the only thing that can cause loculations. Loculation is also associated with hemothorax, represented by that blood red bottle on the lockers, chylothorax, represented by the milky white bottle, and tuberculosis pleuritis, represented by our recurring sketchy cavitary cacti. All of these conditions can cause intense pleural inflammation, which is the first step in producing those thick fibrin layers that form the walls of loculations. Once you've identified a complicated parapneumonic effusion or empyema, your next step should be to get a sample of the fluid for further testing. How do we do that? With a diagnostic thoracentesis. In general, you should poke your patient's chest to sample a parapneumonic effusion if it's loculated, has features suggestive of empyema, like the split pleural sign, or if it's a large free-flowing effusion. How large is large? Well, it's rather arbitrary, but a free-flowing parapneumonic effusion larger than 25 millimeters deep on imaging is typically the cutoff for thoracentesis. Hence the 25 on this fencer's uniform. Analysis of the pleural fluid allows us to figure out what's causing the effusion and therefore tailor our management accordingly. The most common pleural fluid studies for parapneumonic effusions include protein, LDH, glucose, pH, cell count with differential, gram stain, and culture for aerobic, anaerobic, and mycobacterial organisms. Let's break down how these studies guide the management of your patient, starting with the protein and LDH. Sound familiar? Remember, parapneumonic effusions and empyemas produce exudative effusions. So, your first step is to look for one or more of the classic Leitz criteria for exudates, which we reviewed in our sketch on pleural effusions. Head on over to check it out if you want an in-depth refresher on Leitz criteria. That means a pleural fluid protein to serum protein ratio greater than 0.5, a pleural fluid LDH to serum LDH ratio greater than 0.6, or pleural fluid LDH greater than 2/3 the upper limit of normal serum LDH. Once you've established that the effusion is an exudate, it's time to take a look at the other pleural fluid studies. Uncomplicated parapneumonic effusions are pretty boring. The only abnormality you should see in pleural fluid studies is an elevated white blood cell count with neutrophilic predominance, represented by this white-clad neutro first responder taking care of the novice fencer. Uncomplicated parapneumonic effusions are sterile by definition, so you won't see any bacteria on gram stain or culture. Additionally, the pH and glucose of the fluid are normal. Complicated parapneumonic effusions and empyemas, on the other hand, are characterized by all the things that uncomplicated effusions are not. Sure, you'll find leukocytosis with neutrophil predominance on the cell count, but the gram stain, represented by this purple stain on the expert fencer, pH, represented by the acidic lemon juice being squeezed on him, and glucose, represented by this fallen candy bar on the floor, will also be abnormal. Specifically, complicated parapneumonic effusions and empyemas are characterized by a positive gram stain, pH less than 7.2, or glucose less than 60 on pleural fluid analysis. The glucose concentration is low in complicated parapneumonic effusions and empyemas because all the white blood cells and bacteria in the effusion use the glucose as fuel. Finally, the main feature differentiating an empyema from a complicated parapneumonic effusion is the presence of pus in the pleural fluid sample, hence the gooey white sauce oozing from this empanada. Beyond that, the pleural fluid studies are similar to what you'd expect to see in a complicated parapneumonic effusion: a positive gram stain, acidic pH, or low glucose. Let's summarize the clinical presentation of parapneumonic effusion in a sample assessment statement. Miranda Frost is a 44-year-old female with a history of leukemia who presents with fever, cough, and pleuritic chest pain for the past week. Vital signs are significant for a temp of 38.5 degrees Celsius, heart rate of 100, and respiratory rate of 20. Physical exam is significant for decreased breath sounds and decreased tactile fremitus on the left. Chest X-ray is significant for a large left-sided pleural effusion. Loculations were seen on bedside ultrasound of the chest. A diagnostic thoracentesis was performed, and pleural fluid studies are significant for an LDH of 350, protein of 4, pH of 7.1, and glucose of 40. Ms. Frost's labs, in the setting of a likely pneumonia, most likely point to a complicated parapneumonic effusion. Now that you've diagnosed your patient with a parapneumonic effusion, let's get them better. As you might expect, management of parapneumonic effusions depends on which type you're dealing with. The management of uncomplicated parapneumonic effusions focuses on antibiotics targeting the underlying pneumonia. Hence our recurring sketchy symbol, the antibiotic pill bottle-shaped trash can over here in the novice class. In addition, serial chest X-rays, represented by those stacks of chest X-ray-shaped chest plates, or ultrasounds are commonly obtained to monitor for resolution of the effusion. For complicated parapneumonic effusions and empyemas, management gets a little more complicated. You still need to treat the underlying pneumonia with antibiotics. However, since anaerobic bacteria are common causes of complicated effusions and empyema, you'll need to add coverage for anaerobes, represented by our recurring sketchy symbol, the gas mask, if the clinical clues, such as likely aspiration or putrid pleural fluid, point you in that direction. Antibiotics are great and all, but for complicated parapneumonic effusion or empyema, you'll need to go one step further and drain the nasty fluid out of the pleural space. In general, drainage of the effusion is indicated if the pleural fluid shows a pH less than 7.2 or a glucose less than 60, since these effusions are unlikely to resolve without intervention. The preferred method of draining complicated parapneumonic effusions or empyemas is with tube thoracostomy, aka chest tube, represented by this tube sheath holding that epi. If antibiotics in a chest tube aren't enough to resolve the effusion, and they often aren't, especially if your patient has a multiloculated effusion, the next step is surgical debridement and drainage. Hence our recurring sketchy symbol, the surgery scalpel, hanging out in the corner here. Didn't know Shiv was an event at fencing tournaments. Guess I might be able to compete after all. Surgery isn't just limited to draining out that nasty fluid. In severe cases, the pleural fibrosis that results may actually restrict lung expansion. In this situation, decortication, aka removal of the pleura, might be required to achieve full lung re-expansion. Alright, let's wrap up this sketch with a brief review of what we've learned. Parapneumonic effusions, by definition, require the patient to have pneumonia. They can be divided into three categories. Uncomplicated parapneumonic effusions are just exudative effusions full of white blood cells, but no bacteria. Complicated effusions, on the other hand, are defined by bacterial invasion of the pleural space. When this invasion is severe enough to result in purulent pleural fluid, you've got an empyema on your hands. Most of the clinical features of parapneumonic effusions aren't that different from run-of-the-mill pneumonia. However, empyemas tend to occur more frequently in patients with aspiration pneumonia, as well as patients who are immunocompromised. On exam, the main features differentiating a parapneumonic effusion from regular old pneumonia are decreased breath sounds and decreased tactile fremitus. As you might expect with any pleural effusion, a chest X-ray will demonstrate blunting of the costophrenic or cardiophrenic angle. Sometimes you'll see a lateral decubitus chest X-ray being performed to look for loculations, which are pockets of effusions walled off by thick fibrin layers formed by inflammation of the pleura. Nowadays, though, ultrasound and CTs with contrast are the imaging tests most commonly used to evaluate for loculated effusions. If you see a large or loculated effusion on imaging, your next step should be to get a sample of that pleural fluid via diagnostic thoracentesis. Pleural fluid studies will tell you a lot and guide your management, so pay attention. All parapneumonic effusions are exudates, which mean at least one of the Leitz criteria will be true. Check out our pleural effusions DDX sketch for more details on Leitz criteria. Uncomplicated parapneumonic effusions are characterized only by leukocytosis with neutrophil predominance. Complicated effusions and empyemas will have positive gram stains or cultures, low pH, and/or low glucose concentrations. Furthermore, if you see pus in the pleural fluid sample, boom, you've got an empyema. Management of parapneumonic effusions revolves around two things: antibiotics and fluid drainage. For uncomplicated effusions, antibiotics and serial chest imaging is all you'll need. With complicated effusions and empyemas, in addition to antibiotics, you'll most likely need to drain the fluid from the pleural space as well. Drainage of the effusion is indicated if the pleural fluid pH is less than 7.2 or if the glucose concentration is less than 60. A chest tube is the preferred way to drain that fluid, since it's the least invasive, but if that fails, surgical debridement and drainage may be needed. Whew, I'm sure glad practice is over because I'm starving. Let's go get some empanadas. What, too soon?